Welcome back. We will have 4 speakers for the afternoon session. We will also have a short break for you during the afternoon. There will be an opportunity for you to ask questions after our first 2 speakers, so thank you for jotting down your questions in advance. I'm pleased to introduce our first 2 speakers for the afternoon. Dr. Jill Newstead Angel is from Saskatchewan. Prior to entering medical school, she completed 2 years in the College of Nursing. She completed her medical school training in Saskatoon, as well as her internal medicine and general internal medicine fellowships. Dr. Newstead Angel has a clinical fellowship in obstetric medicine from Rhode Island and has also trained in British Columbia and Alberta. Currently, Dr. Newstead Angel has an office in Saskatoon with YXC Women's Health. She also participates on call at Royal University Hospital and occasionally at St. Paul's Hospital for medicine ward call. Dr. Newstead Angel will be presenting on the 2018 Diabetes in Pregnancy Guidelines. Our other speaker for this first session is Dr. Jolie Sasakamoose. Dr. Sasakamoose is an Anishinaabe Ojibwe with membership in the Chaging First Nation in Ontario and is an active citizen of Atakakoop Cree Nation in Saskatchewan. Dr. Sasakamoose is the recently appointed Research Director of the Indigenous Wellness Research Community Network and Wellness Wheel Medical Clinic in Saskatchewan. The Indigenous-led network engages clinicians and physicians as co-researchers in areas of HIV, infectious, chronic disease prevention and treatment, mental health and addictions, and the uses of traditional plant-based medicines with land-based healing for wellness. With funding from multiple agencies, the network is bringing wellness information to First Nations and Métis communities throughout the province. Dr. Sasakamoose is an associate professor in educational psychology and counseling at the University of Regina. In partnership with First Nations communities of Saskatchewan, she co-authored the Indigenous Cultural Responsiveness Theory, a theoretical framework to guide research that improves the health of Indigenous peoples in Saskatchewan. Dr. Sasakamoose also teaches courses on counseling, Indigenous family therapy, and decolonizing research methodologies. So let's get started. Our first speaker is Dr. Newstead Angel.
Thank you for that kind introduction, and it's a pleasure to be presenting today. Now that we've been all fueled from our lunch, we can fuel our minds for the afternoon. So I have no disclosures. Any therapeutic treatments I'm going to be mentioning are straight from the guidelines itself. So the objectives for my talk today are to compare and contrast the 2013 and 2018 guidelines, highlight some notable changes, and review what you need to know about diabetes in pregnancy. So my first comparison is when you actually look at the guidelines between 2008 and 2018, you'll know that they were more in-depth, they're longer, and a lot more references. This just goes into how much research has been done in the area of diabetes and pregnancy over the past couple of years. In 2008, there's only 12 pages, and in 2018, there's 27 pages. So if you have not read them and gone through them yet, I suggest grabbing a cup of coffee and your highlighter and sitting down and going through them, and you'll have some good reading to do. So what's really new in the updated guidelines for gestational diabetes? So we know that the global prevalence is increasing, and it's about 16.9%. The incidence is increasing, and this is due to our obese population, as well as our population that's waiting longer to have children as well. So we see that the prevalence is increasing. In these new guidelines, they do talk about preventative measures, and they mention 3 interventions. However, the only one that's known to make any difference really, that has the most research behind it, is healthy eating. The other 2 recommendations do have a significant reduction in the GDM rates by about 60 to 70%. However, there's only been really 1 study that's been done on them, and so they don't really recommend them at this point in time until more research has been done. So their summary is the only effective preventative measure in early pregnancy, especially those with pre-pregnancy obesity, is healthy diet and close follow-up of weight gain to avoid excessive gestational weight gain. And in our clinic, I know that we really focus on blood sugars and control of blood sugars. And one thing I don't think we always focus as much on is their weight and how much weight they're gaining. We watch them closely to make sure that they're not losing weight, but if they're already obese, we don't really recommend as much about how much weight they should be gaining. And there are recommendations about how much weight you should gain in pregnancy, which I think we could all probably focus a little bit more on, especially if you're involved from the beginning of their care. For screening, they talk about early screening. So we usually screen our women between 24 to 28 weeks. However, in the recommendations, there is recommended for early screening. In the old guidelines, you would recommend screening between 16 to 20 weeks if they've had previous history of gestational diabetes, and you go with the 50 gram or the 75 gram like the old guidelines. However, now they talk about early screening with an A1C or fasting glucose. So with the screening, you're trying to pick out those that truly have overt diabetes kind of at their early first prenatal visit. And we know that if you have a fasting blood sugar of greater than 7 or an A1C of greater than 6.5%, then you do have overt diabetes. And we know that in pregnancy, blood sugars are normally lower than in the non-pregnant state, so blood sugar should be a little bit lower. So with our screening methods, if we use the typical 24 to 28 weeks, that's really not been validated in early pregnancy. And then if we use a fasting blood glucose or the A1C, again, we know that there's that normal decrease in early pregnancy. So what should one do? If you do an early A1C, and if it's between 5.9 to 6.4%, this should set off some little red flags that this person's probably at increased risk or maybe has underlying either metabolic syndrome or impaired glucose tolerance. So in our clinical population, what we would do if we pick this up early, then I'd say, well, now let's go on and do the 75 gram glucose tolerance test to see what's going on. If that's negative, then you could screen again at the usual time. So you might just catch them a little bit earlier than you would prior. When I went to a conference a few years ago in Barcelona, this came up as a topic, and they thought, well, maybe we should change the cutoffs to 5.7 versus 5.9. So as everything in pregnancy and diabetes, it's always fluid and always changing. There's never really a good consensus of what to do, but these current guidelines would say if there's an early A1C of 5.9 to 6.4%, that should raise some highlights that you might need to do earlier testing for them as well. And an A1C of 5.9 to 6.4% in the first trimester has been associated with higher rates of major congenital anomalies, shoulder dystocia, preeclampsia, and prenatal death. So for screening and diagnosis, if you compare these current guidelines to the 2013 guidelines, you really won't see any difference. There was a big change from 2008 to 2013 because we always had the 50 gram, then you went to the 75 gram. However, in 2013, they came up with this alternative approach, and that's based on the International Association of Diabetes and Pregnancy Study Group. And that was based on the HAPO study that had all these different quartiles of blood sugars and found that at a certain cutoff, then there's a higher risk of elevated birth weight and C-peptide levels. So the International Diabetes and Study Group decided was that they're going to try to come up with a consensus so that the world has the same cutoffs. However, we've not gotten there yet. So in the current CDA guidelines, they do acknowledge that there's still some controversy that's going on. And even in our own country, different provinces will have different ways of testing. In Saskatchewan here, we still do the 50 gram and then the 75 gram. And it's felt that the 50 gram is still practical, accepted by pregnant women, and has a 98% negative predictive value. So that's kind of what we do here, and like I say, I know in other provinces they'll sometimes go straight to 75 gram. There's some certain people that you might just want to skip the 50 gram and go to the 75 gram and use those other cutoffs, and that might be your risk of population that they've already had previous history of gestational diabetes, they have a metabolic syndrome, they have PCOS, and you might pick them up a little bit earlier. With the alternative approach, you end up diagnosing about 30% more individuals, and we really haven't seen any change in outcome. So that's why there's still that controversy on which is the one to go for, and that's why the Canadian guidelines recommend the preferred approach, which is the 50 gram, then going to 75 gram. And the cutoffs are in the guidelines, and those cutoffs have not changed from the 2013 guidelines. The other thing that they do bring up in the guidelines is that maternal BMI might be a consideration on which test to do, that in the more obese population, it might be easier to do the 75 gram because maybe when you pick those ones up earlier, having earlier effective treatment might actually change outcomes, where if you have a lower BMI, it's not going to change outcomes as not. What's new and exciting in the guidelines that has not been in the past guidelines at all is the term monogenic diabetes, which is mature onset diabetes of the young. This is more of a genetic defect that occurs. There's many different types of MODY, but in our current population, the three most common ones are MODY 1, 2, and 3. The reason I found this exciting is that in our population, we've had 2 different MODYs that were diagnosed. And in the MODY population, it's more common in the Caucasian population, but it's also in those that you just know that they're not acting like they should. So one of our patients was diagnosed with type 2 diabetes at age 16, which already raises some red flags for me because most people aren't diagnosed with type 2 diabetes at age 16. And her blood sugar levels in pregnancy were more labile, and she was having a lot more lows than I would anticipate. We also had a MODY 3 who was diagnosed with type 1 diabetes about 10 years prior, but she was able to come off of her long-acting insulin in pregnancy. So this is where it kind of raises those little, these people aren't acting like they're supposed to be, and so you can do some screening for MODY. And the interesting thing about MODY is if the MODY 2 people, if they have this gene, which is the GCK gene, and the fetus inherits that gene defect, then treatment can actually be detrimental to the fetus because their glucose levels are set a little bit higher. So if we treat, we end up more for small gestational age babies. So we don't treat those individuals until fetal size indicates needing treatment. So that's the interesting thing, and that's a big difference in the new guidelines than has been in the old guidelines. So management in pregnancy is the biggest thing is avoid excessive weight gain. Again, things that we don't focus on as much, what we should be focusing on. Nutrition management, carbohydrate moderation. We have lots of people that come through clinic that restrict their carbs, think that it's going to manage their blood sugars. This is not something that we advocate. You do need a minimum of 175 grams of carbs. And this is where the teamwork with a dietitian, diabetic educator comes into play. We don't want people restricting their carbs just to control their blood sugars when we have really effective medications so they can still enjoy their food and have a healthy pregnancy outcome. There is some evidence that low glycemic index foods might be more beneficial and reduce large for gestational age babies. Physical activity is recommended, and there are new SOGC guidelines about physical activity in pregnancy as well. So about 150 minutes per week is recommended as long as it's okay obstetrically, and for most parts it is okay obstetrically, so we do recommend physical activity. The guidelines would say, however, they can't recommend any specific intervention, but walking is always a good thing to do. So for glycemic control, what is new in these guidelines is they actually have a lower cutoff. In the 2013 guidelines, they really didn't talk about lower cutoffs. In the 2008 guidelines, they did have lower cutoffs. However, we know that in pregnancy, blood glucose can go as low as 3.3. However, we recommend if you can keep their blood sugar greater than 3.7 is recommended to avoid repeated lows. They don't really have any upper limits on their fasting blood glucose. They do mention that a fasting blood glucose of less than 5 may have a protective effect on macrosomia, neonatal hypoglycemia, hyperbilirubinemia, and preeclampsia. And there's a really interesting comment in the guidelines about adjusting glycemic targets based on abdominal circumference, which I find is really quite fascinating. So this would be just ensuring that they have good fetal surveillance, and if they have their ultrasound at 32 weeks that shows the abdominal circumference is greater than 75%, you could potentially tighten up their targets so that their fasting blood glucose is less than 4.5 and 2 hours between 5.6 and 6.1. If on their ultrasounds the abdominal circumference is not showing any large for gestational age babies, if their glycemic targets are not that less than 5.3 or less than 7.8, that's okay, and you can target maybe some higher sugars. The number needed to treat is about 10 to prevent a large for gestational age baby, which is quite good. However, they do say right now that caution should be used at interpreting this at this point in time. And we all know that we have those certain groups of individuals that just have what I say pesky fasting blood sugars. We do everything we can to bring them down, and they're still a little bit above target. But if their baby's not large for gestational age, then maybe we don't have to drive them down to less than 5.3. And if they have a 5.5, that's okay. And one of our other patients, she had really good glycemic targets, but she did have a large baby, and she did have a stillbirth previously. So we actually aimed for lower glycemic targets in her and did deliver early for her to avoid the same outcome. So this is where the art comes in, and that fetal surveillance, and again, working with your team of individuals to help achieve a good outcome. The other thing that they mention in the guidelines is about e-medicine and telemedicine, is that this is an effective way to help women manage their diabetes in pregnancy. And it is a way to reduce coming for appointments, because we know that in Saskatoon here we have people coming from up north, and we try really hard to coordinate their appointments with their care providers. But if they can do emails or telemedicine. Some people have apps, some centers have apps that they can go on, and then that can achieve their glycemic control as well. For pharmacological treatment, there have been some changes from the previous guidelines, and such that insulin and metformin are recommended as treatments. In the old guidelines, metformin used to be off-label. However, in the new guidelines, it is mentioned as one of the agents that can be used for treatment. The only thing I found in the guidelines that they don't really recommend is which one to use and when. So I find that if people have high fasting blood sugars only, using metformin isn't really going to be as effective. So then I'll go to insulin at bedtime for their treatment. If their blood sugars are mildly above target and they're needing treatment, in that group, I would recommend an option of metformin or insulin. But we do talk about the benefits and the risks and the side effects of them both, and give it patient the chance to make an informed decision. So metformin, we do know crosses the placenta, but in the past couple of years we've had a lot more research about metformin. There was a MIG study, which is metformin in gestational diabetes, and it found that patients were more accepting of the treatment. There's less hypertension, less weight gain. There was a tendency to deliver around 36 weeks, so that's one of the things that came up in that study, but they did find that they'd still achieve good glycemic control. Sometimes you do have to add insulin onto the metformin to achieve good glycemic control. So we give the patients the option that these are your two options. If they're really high, I don't really mention metformin, and I'll just say I think we should just go straight to insulin and tell them that insulin does not cross the placenta, but there is a risk of having low blood sugars. So insulin and metformin work in different ways. As you're all aware, metformin decreases insulin resistance, and that's one of the driving forces behind diabetes and pregnancy is all the placental hormones which cause insulin resistance. So that's where the metformin can help with that. But again, if their blood sugars are quite high, I will recommend insulin initially. And if we're going up on their insulin requirements a fair bit, we'll sometimes add metformin so we can decrease the insulin doses a little bit as well. In the old guidelines, glyburide was mentioned as an acceptable second-line agent. However, in the new guidelines, it's been taken out, and it's more of a third-line agent. It can cause a few more lows, a little bit harder to manage as well. So if people are not doing well on metformin yet still refuse insulin, then you can use glyburide as well. The newer agents are still not recommended in pregnancy. We don't have as much information about them. They're also not recommended in breastfeeding because of the size of them, they do cross into the breast milk. And intrapartum, no real big changes. We still recommend blood sugars less than 7 before starting any insulin. Goals around 4 to 7. Although they do mention in the guidelines that there are no specific protocols, and each center should have their own protocol. In Saskatoon, we do have intrapartum goals. I know in Regina, they do have their own intrapartum, and in Prince Albert, they have their own intrapartum as well. And so these options are available, and now that we're one big health authority, we'll hopefully in the next couple of years having one set of orders for everybody. We always do recommend breastfeeding in these women. However, we know that the uptake with breastfeeding is a little bit more difficult at times, and they don't always achieve the same duration. It's a little bit harder. So just supporting these women for breastfeeding as well. And the minimum is 4 months, and it is found to have a reduced risk of type 2 diabetes in the women that have gestational diabetes, and less obesity in the offspring as well. The biggest thing that I really want to focus on is postpartum testing. We have done a research in Saskatoon, and our postpartum testing rates are about 21%, which are just dismal, I must say. And after 16 years, about 40% of women with gestational diabetes are at risk of developing type 2 diabetes. So this is a large group of women that we could potentially pick up, that maybe they have underlying impaired glucose tolerance or impaired fasting glucose, so that they're pre-diabetic group that we can pick up and make interventions early and get them screened early as well in the future to make sure that they don't progress to diabetes, or if they do progress to diabetes, that we've caught them earlier. In some lean women that have gestational diabetes, again, you might think you're not like you should, and maybe we should do some other testing. You might be diagnosing a type 1. We've diagnosed a few type 1s that have been picked up in pregnancy, and then their postpartum testing was positive. Across the board, only about 14 to 50% of people do return for the annual test or their testing for postpartum screening. So this is a thing that I really want to be focusing on in the future, is this postpartum testing. The current guidelines still recommend going for the 2-hour GTT. This is hard for women to do because it's 2 hours out of your time. It's a fasting test. So the current guidelines have not changed that recommendation. I'd hope in the future that they might change it, because I think that's one of the areas where we hamper testing. In our clinic, we usually recommend about 3 months postpartum going for testing, because then you've probably lost most of your pregnancy weight. Your baby's old enough that if you made them sit there with you for 2 hours, it's not going to be as disastrous as if you have a 6-week baby. So the uptake might be a little bit better. There's been some thought about why don't we just do an A1C at 3 months or a fasting glucose. But again, if you do an A1C, you might not pick up that impaired fasting glucose. If you just do a fasting glucose, you might be missing the impaired glucose tolerance. So that's kind of why they haven't changed their recommendations on that. But I always say any form of postpartum glucose testing is okay, and if you pick somebody up, that's always great. So the highlights, I must say, from the gestational diabetes area are the early screening that they mentioned with the A1C of 5.9 to 6.4%. Metformin is acceptable as an agent for first-line treatment. Glybride is now a third-line agent. They do mention this MODI testing, and then the potential for future guidelines to adjust glycemic targets based on fetal growth. So for pre-existing diabetics, this is diabetes diagnosed before pregnancy, such as type 1 or type 2. We do recommend preconception care. They do find that people with type 2 diabetes do not get the same amount of preconception care as those with type 1, so that's an area to focus on. It's probably because they may be on oral medications, not checking as much, not needing that same intensive treatment that type 1s do on insulin, so that's an area to keep in the back of your mind to focus on this group of individuals. The folic acid supplementation has changed. In the old guidelines, it was 5 milligrams 3 months prior to conception and for the first 3 months of pregnancy. However, these guidelines have changed from the 2015 SOGC guidelines recommending 1 milligram. So we recommend 1 milligram for the first 3 months pre-conception and first 3 months of conception. You can buy that in your prenatal vitamin. Those that would require 5 milligrams are those with a previous history of neural tube defects. So they did find that the higher dose of folic acid might be associated with atopy in the children, so that's why they reduced it. Although they do say in obese individuals, serum folate levels might be a little bit lower, so in those individuals you might recommend the 5 milligrams. And again, 50% of women do not receive interdisciplinary care, and that's what they would recommend, is that interdisciplinary care for these women for preconception counseling. For complications, kind of like the old ones, retinopathy is one of them, and making sure that they get their eye appointments prior to conception and in pregnancy as well. They talk about laser photocoagulation, which is acceptable. And new in the guidelines, what we've always been kind of afraid about in the past, if they have a history of retinopathy, you would kind of say, well, maybe you shouldn't have a vaginal delivery. However, if they have stable retinopathy, there is no contraindication for having a vaginal delivery. They do talk about these newer treatments, such as the intravitreal growth factors, which are not recommended in pregnancy, and if you do get them, to avoid pregnancy for 3 months. However, there's also a thought that if you're going blind, it's a treatment, it's probably not going to pass through the placenta. So in those rare complications, in discussion with their ophthalmologist, that might be something to be considered. But again, the current recommendations would be to wait as well. For hypertension, so there's a 40 to 45% incidence of hypertension complicating pregnancy. Type 1s tend to have more associated with preeclampsia. Type 2s more have an association with chronic hypertension. So in the past few years, we have been recommending aspirin prophylaxis for these individuals to reduce their risk of hypertensive disorders. And there have been some more studies about this. And so we do recommend 162 milligrams to start after 12 weeks gestational age and before 12 weeks gestational age to reduce the risk of hypertension in pregnancy. We know that these individuals are at higher risk, and this is something that we can do to prevent their risk of hypertension in pregnancy. We also recommend good calcium supplementation, and if you ask about their diet, if they're not having good calcium, then to increase their supplementation so they're taking at least 1 gram per day. For chronic kidney disease, prior to conception, to screen for it, because we know that proteinuria does increase in pregnancy, and if they already have some proteinuria, it may get worse. And they do recommend not using the GFR, but following the creatinine in pregnancy to monitor their renal disease, because GFR will change in pregnancy and may not indicate any adverse progression of their renal disease. When we screen for proteinuria, if you've been following an albumin-creatinine ratio in these individuals, do continue to follow it throughout pregnancy on their every 3-month blood work as well. And then blood pressure goals for these individuals, if you go through the hypertension guidelines, the guidelines would be a treatment or goal blood pressure 130 to 140 over 80 to 90. And there has been the CHIP study that came out that did recommend a blood pressure of 135 over 85. And new international guidelines would recommend blood pressure management of that as well. And keeping that blood pressure to avoid that risk of hypertension getting worse in pregnancy. When we have these individuals as well, we know that most of them are on an ACE or an ARB preconception to avoid any progression of their nephropathy. These are not recommended in pregnancy. If they're really on it and their ACR is less than 1 and they really don't have any progression, you could stop it prior to conception and just follow them. If they're on it for blood pressure control with no ACR that's greater than 1, then you can switch them to another medication. I say though, if these individuals are on higher doses of ACEs and ARBs because they have a higher proteinuria, then I don't know how long it's going to take them to conceive, and I ask them to hold it. It might take them 2 years and their disease might progress. So again, it's very individualized. If they're on it specifically for proteinuria, you could say you can stay on it, but do monthly pregnancy tests and stop as soon as you become pregnant. So again, very individualized. We used to say that they were okay in the first trimester or as soon as they find out they're pregnant, but now they might be associated with some increased risk of malformation. So again, that discussion with if they're following with a nephrologist as well for that. They mentioned about neuropathy, and gabapentin treatment is acceptable. If you're using bigger doses of 600 milligrams 3 times a day, there is a risk of neonatal withdrawal as well, so just keep that in mind. And cardiovascular disease, they mentioned these women are at higher risk of any adverse conditions if they have cardiovascular disease in pregnancy. So if they've had previous cardiovascular disease, to let them know that their risk is increased and to follow them closely. And again, statins and fibrates should be discontinued prior to pregnancy. So for glycemic control, again, in this time, they do mention lower blood glucose of 3.7 again. And we want our targets to be less than 5.3 for fasting, and before meals, less than 7.8 1 hour after. So in the guidelines, they mentioned the fasting and preprandial of 5.3, less than 7.5. And again, they just kind of combine with the GDM of the 7.8, and that's where that comes in. And we should strive for an A1C of less than 6.5 in pregnancy, ideally less than 7% for preconception. And if you can achieve an A1C of less than 6.1% in the 3rd trimester, that would be ideal as well. Again, we always want to watch for lows though. We don't want to try to achieve these targets and that they have a lot of lows trying to achieve this. So if they have a slightly higher A1C but more stable blood sugars, because lots of lows would indicate poor glycemic control as well. Again, that definition of hypoglycemia, which has not been in previous guidelines. So traditionally defined as less than 4, now it's less than 3.7. And the thing that they mentioned in this one, which hasn't really been mentioned before, is that discussing with your pre-existing type 1 or type 2 diabetics that are on insulin to avoid the lows and to have a glucagon kit, to make sure that their family members and their co-workers also know that they have diabetes in pregnancy. We know that in the early part of pregnancy, you're a lot more sensitive to the insulin that you have, and blood sugars are actually lower in the 1st trimester. And then the insulin resistant kicks in around 18 weeks gestational age. So just having them monitor for those lows in that first part of pregnancy, they can back off on their insulin as needed. If they have significant nausea and vomiting in pregnancy, to make them aware that again, they're at higher risk of lows if they're going to give themselves insulin before they eat, and then they throw up their meal, then they're at risk of a low. And we want to avoid those lows because they can sometimes drop down pretty low. So making sure that their family members and friends are aware and that they have treatments available to them. And then weight gain, again, same as for gestational diabetes. We want to ensure that we have adequate weight gain in pregnancy. And so for people with a normal BMI, the weight gain is recommended to be 25 to 35 pounds in pregnancy. For those that are 25 to 30 for a BMI, the weight gain is recommended to be 15 to 25 pounds. And for those with a BMI of greater than 30, the recommended weight gain is 11 to 20 pounds. And so in the 1st trimester, they really shouldn't gain very much weight. But a good thing to remember is in the 2nd and 3rd trimester, if you're a normal BMI, your weight gain should be about 1 pound per week. If you're overweight or obese, your weight gain should be about 0.5 pounds per week. So good numbers to keep in the back of your mind when you're seeing these women and just watching their weight in their pregnancy and counseling them as well. And if you have a good weight gain in pregnancy, you're going to lower your risk of large for gestational age babies, macrosomia, and operative deliveries. Again, our options for treatment. If the type 2s are on metformin, they can remain on their metformin and then add insulin as needed. If they're on metformin plus some of the newer agents, ideally preconception, you would want to switch them to insulin for good glycemic control so that they're not on the newer agents when they conceive. Again, we don't have as much data about them. So we still recommend using the rapid-acting, long-acting, and pumps. Epidra's not recommended as yet just because we don't have as much information, but if people are on it, then I don't usually switch them to something else, especially if it's in their pump either. Again, the oral agents, they can continue on until they need metformin. I usually will switch my patients on glyburide though to insulin a little bit sooner. Again, I just find that they tend to have a few more lows. I don't see as much glyburide being used anymore. It's usually more dimicron, which again, we don't have as much information about in pregnancy. So I usually switch them to insulin if needed. The one thing I really like about these new guidelines, and I was very excited to see, is that they actually have an algorithm to prevent DKA or hypoglycemia with steroids. So some people come in earlier in pregnancy than their planned time for delivery, and they need steroids for fetal lung maturity. And we know that when we give them their dose of betamethasone, their 2 doses, their blood sugars just skyrocket. And then we always play that we're playing a day catch-up. We'll increase their insulin and then increase it the next day and increase it the next day. So it was great when they came out with these guidelines on how to increase their insulin in the time that they're getting the steroids. So it's a little bit harder to see on the TV screen, but hopefully on the handout it's a little bit easier to read, and it is in the guidelines on how to increase their nighttime insulin and their daytime insulin. And again, it's just so nice to see this because it will actually help us manage the patients, because usually we're playing a day behind and then we end up with high blood sugars that we're playing catch up. And then once we've got them, their steroid effect worn off, then we're dealing with low blood sugars that we have to come off. So I was really excited to see this in the new guidelines. What they've talked about in the new guidelines, what they have not talked about in the past, is the significance of decreasing insulin requirements. So it's really not certain. When I was going through my training, there was a thought of, oh, if they've got decreasing insulin requirements, we know that the placenta's not doing well. In the big endocrinology textbook, it says if there's a significant drop in insulin requirements, then we're concerned about placental sufficiency. However, no one's really been able to come up with a certain cutoff. So they have looked at this, and about a 15% has been noted, but again, it's thought that if you notice a drop in their insulin requirements, it might just be a normal physiological drop. We expect insulin requirements to go up from 18 to 20 weeks up to about 36 weeks, and then they plateau and then come back down. But what kind of plateau and how much they come down is significant for pre-existing diabetics. Again, we know that the placenta is the main driver of this insulin resistance. So if we have a large drop, do we have to be concerned about placental insufficiency? We keep this in the back of our mind when we see our patients. We talk to our obstetrician colleagues and say, you know what, they've had a pretty big drop of their insulin requirements, and they'll say, well, baby's doing pretty good, but we'll bring them back a little bit more for fetal surveillance. But they do say that fetal monitoring should not be viewed as a substitute for a well thought out plan for delivery as well. So again, that's where that coordinated care comes in. If you notice that this is going on, keep in touch with their delivering doctor, their obstetrician, about this drop in insulin requirements. They mention obstetrical considerations such as fetal surveillance, and this is another highlight I'd like to recommend or just talk about, is that these women do need fetal surveillance. Even our gestational diabetics do need fetal surveillance, especially if they're on insulin. They do need to have some non-stress tests, biophysical profiles. We have a number of our patients here that are being followed and they're on insulin, but they're just not getting that fetal surveillance. So we just always encourage them to mention to their care providers that they're on insulin now, and is there any increased fetal surveillance that they should have? There's specific guidelines from our fetal assessment unit about what should be done, and there is no single strategy for antenatal surveillance for pre-existing diabetes, but there should be some form. So here they'll usually get a biophysical profile every 2 weeks, and if needed, they might get a non-stress test every week by the end, depending on what's going on. Again, if their blood pressure is going up, if their insulin requirements are dropping, they might get more frequent, but they do talk about it as well. So the initiation of weekly assessments should be recommended between 34 to 36 weeks. And then for postpartum, we know that insulin requirements do decrease after the delivery of the baby. We know that they can go down by about 50%. So when I'm seeing these ladies in clinic and they're getting ready to deliver, we always go back to their early pregnancy insulin requirements or their pre-pregnancy insulin requirements to have an idea of what they were. So it's great to have an EMR of some sort and not just a piece of paper somewhere in there that you have to flip through to find, so that you know what their insulin requirements were earlier. Because once that placenta is delivered, their insulin requirements drop a lot, and so you want to know how much they were on before so you can make some plan for what they should do after. So we usually say about 50% that first day and about 2/3 after that. Usually I'll go through their doses, and if I see them at 7 weeks, I'll have how much they were on, I'll do the calculations, and in their postpartum plan I'll have their early pregnancy or their pre-pregnancy doses, then we'll have their current doses, and then we'll have their plan for how much they should take after. The thing that we want to avoid again is having lows after the baby is born, and so we want them to cut back on their insulin a fair bit, and I let them ride a little bit higher. I'll let them ride about a blood sugar of 6 to 10 after delivery. So I really focus on the fact that we no longer have to achieve our pregnancy targets. We can loosen up a little bit, and always recommend when they're breastfeeding that they have a snack to avoid those lows, especially at night. So the higher blood sugars when you're breastfeeding are not going to affect the baby in any way. So not to focus on really tight targets anymore. And that's hard to do when you've had really tight targets for 9 months. It's hard to back off a little bit. Again, with breastfeeding, we know that those with underlying diabetes, it's a lower initiation and they don't breastfeed for as long. There is delayed lactation. And so just supporting them in this time and recognizing how hard it is and recommending about 4 months, but longer if they can. So just getting that lactation consultant if you have them available, helping them out, letting them know it's not easy, it's going to take a little bit of time, and just that support for them. So the highlights from the pre-existing diabetics are that they now give blood glucose levels for hypoglycemia. They do give options for steroid management. They talk about fetal surveillance, a little bit more focus on weight gain as well, the aspirin for hypertension prevention, and the folic acid of 1 milligram, not 5 milligrams like it has been in the past. So overall, there's no major changes. I find that there's more information, they're more comprehensive. If you go through the list of references, then you can kind of pick out where they get their studies from and read those, which is great. And this just indicates the amount of work that has been done and that's currently being done, and I think will be done in the future as well. Metformin, again, is an option, and if type 2s are on it, they can stay on it. And again, that early screening for gestational diabetes as well. So I just want to run through a really quick case towards the end of this. I think I've got a few minutes. So we had a 29-year-old G0P1. Her 50 gram was done about the 26 weeks, and it was 15 millimoles. So we know that she's quite positive for her, her diabetes. She ended up having a 75 gram as well. So this is one area I want to highlight. If they have a positive 50 gram, they do not have to go on and have a 75 gram. So the cutoff is 11. If it's greater than 11, you do not have to have a 75 gram. She ended up having both, and it shows that her fasting was 9.7, her 1 hour was 17.8, and her 2 hours 21.1. Again, this is a lean individual, so a few red flags that this is just a little bit abnormal. So because she was picked up at the usual time in pregnancy, she was diagnosed with gestational diabetes. So for her, treatment options, diet and exercise for the first few weeks like usual, and then options being metformin or insulin. In this individual, she was really good about jotting down her blood sugars. They were all above target. She was tried initially on some metformin, however did need some insulin on it as well. And then following her blood sugars were a little bit more labile. So again, usually I find some increased insulin resistance. Don't usually see as many lows, but she was a little bit more labile with her insulin. We ended up going with N at twice a day plus some Humalog with her, and had a few more issues with her blood sugars. Postpartum, after she delivered, we stopped all of her treatment like we do on everybody with gestational diabetes. However, she was still checking her blood sugars, which is strongly recommended for some people that just don't fit the norm. And she found that her fastings were still elevated and her PC meals were still high depending on what she ate. Her A1C in pregnancy was 5.9, or sorry, her A1C at 6 weeks was 5.9. However, in pregnancy when he tested her, it was about 7%. So again, that's a little bit higher. I have done A1Cs in my gestational diabetics that are just purely gestational and just have the slightly abnormal tests and not as high as hers. And they're usually about 4.3 to 5. So to get an A1C of 7% knows that I've been on, she's been higher longer than we anticipated. So when she went for postpartum 75 gram, her fasting was 8 and our 2-hour PC was 17. So thoughts on her is that she is truly a diabetic. She's not a type 2 diabetic because of the way that she presents, and she's actually quite lean. And we did do testing for her for insulin antibodies in pregnancy, which were negative. We did do MODY testing on her, which was negative. We retested her for her insulin antibodies, and on the retest, those came up positive. So she was a type 1 diabetic. So I always say these highlight the cases of those that just don't fit your norm, are a fair bit higher than you think, to keep in the back of your mind other testing that might need to be done to help determine what sort of diabetes that they have. So my references are the diabetes guidelines. The diabetes app is a great app for those that don't have it on their phone. It's a really good app to have. And I'll take any questions at the time of questions.
Thank you very much for your very informative presentation, Dr. Newstead Angel, and for providing suggestions for the best practice care of women, both with pre-existing and gestational diabetes. I'm going to use my privilege as moderator again just to make a comment or ask a question about your presentation, and then we'll move to our next speaker and then formal question period. You mentioned research that has been done and that was been done in Saskatoon. Where do you think research on type 2 diabetes in pregnancy should be focused? And are there research programs going on right now that are focused on those areas?
So in Saskatoon, we don't have a lot of research ongoing at this point in time. We have a research project on our postpartum screening that we're doing because we know it's so dismal, and on ways that we can improve that. That's a research project that's currently going on. Research with the type 2s, there's currently the MIGHTY study that's going on, which is metformin in type 2 diabetes, and that's out of Toronto with Denise Faig. And we were involved in that study for a little bit initially, but we haven't progressed, but that will be hopefully presented next while, and they'll be following the kids out of that as well. So. And
is there a focus on all women with gestational diabetes, or is there a specific focus on First Nations women? Currently, we don't have a focus on First Nations. We kind of just have our whole group. They're included in the whole group, yeah. Although when we were looking at our current clinics that we have in Saskatoon, we used to only have one clinic at RUH, and then our numbers increased so much, and we had a large no-show rate, so we actually mapped out the postal codes of where we had our no-shows and found that if we had another clinic over on the west side at the West Winds Clinic, we've now got 2 clinics which are able to capture a greater amount of our population and have a much less no-show rate, because that's an area not only of the First Nations but also our other ethnic populations that we are able to accommodate, because coming to RUH, as most people know, is quite difficult to find parking and just to come to clinic as well. So. Mm-hmm. And then you mentioned telemedicine and telehealth. Is there an opportunity to provide clinics to rural and northern remote areas of Saskatchewan as well? We have done that in the past. The only thing that we found that was hard to accommodate us and the other population as well. We would only sometimes have one person to show up to clinic, so it was hard to coordinate with here and the other sites, but it's definitely something that we can look at. And I find that the people that are from up north, the physicians, they're doing a great job managing them already, and if they need our help, they can help
we can set it up again, because it's something that we should be able to look at. We have a lot of these women that come down for their fetal surveillance, because that's the highlight, is to come to Saskatoon, get that fetal surveillance, because, or else Prince Albert as well is an option to get fetal surveillance, because there's clinics up there, because that's the area that I also want them to be focusing on, is that making sure baby's growing well, doing well, to prevent those stillbirths and adverse outcomes. So we'll coordinate care that way. So if they're coming from up north for their assessments, we'll coordinate an appointment with them if we can in our diabetes and pregnancy clinic, or else someone will see them outside of that as well.
Okay, thank you for that additional information.